This is Christiana Coleman. My professional development is on disenfranchised grief of prenatal loss, and I title it Applying Evidence-Based Assessments to Prenatal Loss, be it miscarriage or stillbirth, clinical guidance for trauma, grief, and loss practice. Introduction, background, and clinical framing. Despite its frequency, miscarriage and stillbirth are underdetected in terms of psychological consequences of the loss, and clients are often misclassified or inadequately supported, especially when spiritual meaning making and cultural context are central. Perinatal loss is a very widespread issue, and miscarriages often occur during about 10 to 20% of known pregnancies, and stillbirth is a frequent negative outcome that non-Hispanic blacks disproportionately encounter. WHO 2024. Psychological consequences of perinatal loss include, but not limited to, acute grief, depression, post-traumatic stress disorder, sleep disturbances, and identity disruption, and so on. These consequences arise and may persist unless specific interventions are applied to them. Psychological predisposition of mental disorders, traumatic perinatal experiences, low social support, and stigmatization reactions to the loss make this risk more severe. My presentation hypothesizes an evidence-based, culturally responsive assessment model of perinatal loss in African American Christian women and proposes its combination of grief and trauma, as well as spiritual coping indicators. Learning objectives. At the end of this presentation, it is expected that clinicians will be able to select and sequence evidence-based assessment tools appropriate to perinatal loss. 2. Implement an ethical, phase-sensitive, measurement-based workflow. And 3. Interpret results with cultural and spiritual awareness, including religious coping and congregational dynamics. Assessment landscape for perinatal loss. A clinically useful assessment pathway for perinatal loss should sequence grief-specific measures with perinatal comorbidity and spiritual cultural tools. The goal is to clarify presentation without pathologizing normative grief. It is also to guide triage and treatment planning and support measurement-based care in a way that is culturally and spiritually responsive, particularly for African American Christian women. Assessment tools. Suggested assessment tools include 1. Grief-specific measures. For grief-specific measures, I am proposing prolonged grief disorder -13, PG-13, or inventory of complicated prolonged grief, ICG, or IPG. These instruments measure symptom severity, provides diagnostic support, and enable treatment monitoring across care episodes. The ICG, that's the inventory of complicated grief, remains widely used. Both instruments assess yearning and longing, identity disruption, avoidance, emotional pain, functional impact based on time since the loss threshold. Uh, my advice is that we reassess clients every 4 to 6 weeks for stepped care decisions in psychotherapy. Another grief-specific measure is traumatic grief inventory, clinician administered, that's TGI-CA, traumatic grief inventory, clinician administered. This instrument is useful in the case of trauma-related grief, e.g. emergency delivery, medically traumatic events, and so on. It favors divergent evaluation of separation distress and traumatic reaction related to bereavement. For perinatal specific grief measure, Perinatal Grief Scale (PGS) can be used. The PGS is a direct measure of perinatal grief related to the intensity of grief across 3 subscales: active grief, difficulty coping, and despair. This scale has been found relevant following certain miscarriage or post-stillbirth. For comorbidity screens, PCL5 can be used for PTSD, PHQ-9 for depression, and GAD-7 for anxiety. These tools identify overlapping syndromes typical of the postnatal death, support risk classification, and level of care and referral. PTSD screen, the PCL5, evaluates symptoms clusters, that is, intrusions, avoidance, negative alterations, and arousal, and it is relevant in cases when a distressing medical history has occurred or traumatic recollection. PHQ-9 indexes depression severity and lack of functional ability, while the GAD-7 is focused on the level of generalized anxiety and worry. For perinatal mood tool, the Edinburgh Postnatal Depression Scale (EPDS) can be used. The EPDS is a 10-item sensitive and well-validated perinatal depression screen, sensitive to guilt, and has a self-harm suicide item that demands urgent clinical follow-up when positive. Please note that despite being created within the perinatal specific period, the EPDS is still applicable in post-loss depression to identify clinically significant depressive symptoms, which might accompany grief, plan safety, and integrate treatment. For spiritual and cultural context measures, brief religious coping can be used. That's brief RCOPE, brief RCOPE can be used. And spiritual well-being scale, that's SWBS. The brief article categorizes positive, e.g., benevolent reappraisal, spiritual support, and negative, for example, divine punishment, spiritual discontent, religious coping, which may contribute to the development of hopelessness and shame. While the SWBS, the Spiritual Well-Being Scale, gives a bigger picture of existential and religious well-being. These tools help clinicians map spiritual resources versus struggle. It informs spiritually integrated psychotherapy and determine when a chaplain or pastoral referral might be supportive. In African American Christian context, they surface congregational dynamics like silence or it's God's will explanations that may either comfort or harm the client. Under the religious and cultural specific measure, DSM-5 cultural formulation interview CFI can also be used. The CFI provides a conversational scaffold to elicit the cultural meaning of loss, preferred help-seeking norms, and the role of church, family, and community. Putting the tools together. A phase-sensitive pathway might proceed as follows. At intake, administer PGS to index perinatal grief intensity, PHQ-9 and APDS to survey mood and safety, and brief RCOP plus CFI to surface spiritual or cultural context. When trauma features are prominent, add PCL5. When grief appears prolonged or functionally impairing beyond diagnostic windows, you can introduce PG-13 or ICG. For PGD clarification and TGICA, where trauma-like grief is suspected. Reassess every 4 to 6 weeks to monitor change, adjust care, and coordinate referrals. Throughout, frame scores as conversation starters, not verdicts. Invite client meaning making. Check for cultural fit. And partner with a pastor or chaplain when and if desired by the client for pastoral or chaplaincy support. Clinical application. The case of Vignet. This is a 32-year-old African-American Christian female who is 4 months post-miscarriage in the first trimester. She is very active in the church. She states that she is sad, feels guilty, cannot sleep, and does not want to go to baby-related events. The reaction of congregations are ambivalent. Women's fraternity is helpful, yet one of the leaders interprets the loss as a demonstration of the will of God, which increases received shame. She is afraid of pregnancy and later on and is not connected with her partner. Goal. The goal of treatment is to validate grief, assess severity and function, screen comorbidities, map religious coping, and recreate a plan that respects faith and culture. For this client at intake, the PGS, PHQ-9, EPDS, the brief RCOP, and selected CFI models were used. Illustrative results. The PGS elevated on difficulty coping or despair. PHQ-9 moderates. APDS elevated, no self-harm, while brief RCOPE shows negative religious coping. CFI reveals congregational silence, increased shame and isolation. The interpretation of this: the clinically significant grief with depression symptoms, spiritual struggle is a priority target alongside sleep and couple communication. Conclusion and professional development takeaways. Perinatal loss requires phase-sensitive evaluation with moral uprightness that separates normal from PGD, PTSD, MDD, and incorporates culture and religion. 2. In the case of perinatal loss, apply a sequenced battery as it has been described in when putting all this together. PGS plus PG13, PCL5, PHQ9, APDS, brief RCOPE, and CHI. Use numbers as a discussion point, not a decision point. Make the plan, that is the treatment plan, based on the needs of the client per time. Important interventions will be face matching devices, peer scale with CFI, integrate spiritual activities, checkups every 4 to 6 weeks, and connect clients to referrals where necessary. Thank you. Thank you for listening. Any questions? I sincerely appreciate your time. Thank you again. I will be posting the Word document. The Word document is very detailed, but for reasons of time cannot come on these slides. So please make time to read the Word document. Thank you so much. Thank you so much.